Hey guys, so this presentation will be on organic depression, so depression that's secondary to other causes. And this will just go through patient presentation, differentials, history and examination, and investigations. Case presentation. A 78-year-old woman presents with what appears to be major depression of 5 months duration. At the time you see her, she has already been treated with sertraline for 7 weeks at a dose of 50 to 100 milligrams per day with no improvement. Her lack of response makes you suspect that she may have an organic depression. Which physical disorders are most likely to present as depression in her, and how will you investigate her? So, in terms of differentials, you need to divide it into both psychiatric and non psychiatric causes. Psychiatric causes can be depression, bipolar disorder, anxiety disorder, and forms of psychotic disorders such as schizophrenia, schizoaffective, and schizophreniform. In terms of differentials for non psychiatric, drugs include alcohol, stimulant withdrawal such as cocaine and methamphetamines, neuroleptics such as antipsychotics, therapeutics such as steroids, interferons for hepatitis, beta blockers, and levodopa. In terms of organic causes, these can be divided into neurological, cardiac, hematological, malignancy, endocrine, autoimmune, and infectious causes. The most common is definitely neurological, whereby patients often present looking like depression, but they actually have underlying dementia, such as Alzheimer's disease or frontotemporal dementia. They can also have cerebrovascular accidents, stroke, Parkinson's, and Huntington's disease. In terms of cardiac, they can have congestive cardiac failure after a myocardial infarct and coronary artery bypass grafts. Hematological differentials for depression, anemia can often result in the patient looking lethargic and quite tired. Malignancy is an important one, so they could have brain tumor, and that this could be resulting in their depressive mood. And this includes both primary brain tumors and secondary tumors. So if they have a history of a certain cancer, such as colorectal or lung cancer, think about secondary metastases to the brain resulting in their depression. Endocrine, a lot of hormone dysregulation can result in depression. So, Cushing's disease, Addison's disease, hyper or hypothyroidism, hyper and hypocalcemia. This is interesting. Autoimmune disease include systemic lupus erythematosus, giant cell arteritis, and vasculitis, and infectious causes include infectious mononucleosis. In terms of history, do a MSE, and then also ask about questions that may suggest an organic secondary cause, such as a late onset elderly patient. Usually, patients with depression, the peak at which it's diagnosed is usually in the late adolescent. If an late onset elderly patient comes with depression, think about maybe there might be a secondary cause, such as the ones listed before, in particular dementia. If you've been treating them for more than 4 to 8 weeks and they have zero improvement with the treatment, they're resistant to treatment, and maybe they don't have depression when you give them antidepressants. Atypical symptoms include if you're thinking of psychotic depression, but they have no psychomotor retardation. And if the patient complains of hallucinations, this is very unusual in all types of depression. If they have a severe and rapid onset of symptoms, again, this is usually not found in depression because it gradually comes on. The presence of other neurological dysfunctions, such as aphasia, suggests an underlying neurological problem, such as a brain tumor or dementia or a stroke, and the presence of other medical disorders, for example, hypothyroidism. After this history, we must devise a formulation for the patient's disease, assessing the presence of predisposing, precipitating, perpetuating, and protective factors. In terms of investigations for organic depression, these can be divided into 3 main groups: bedside investigation, bloods, and imaging. Bedside includes an ECG, just to look for potentially a previous myocardial infarct, which would result in deep Q waves. Bloods, they can have a full blood count to check for anemia, EUCs to look for chronic renal failure, CMP to look especially for calcium, because hypo and hypercalcemia, as I said before, can lead to depressive-like symptoms, liver function test for chronic liver disease, vitamin B12 and folate deficiency, thyroid stimulating hormone, which would be elevated in hypothyroidism, blood and urine toxicology screen, including alcohol, blood-borne virus screen, in particular HIV, dexamethasone suppression test for Cushing's disease, and autoantibody screen if necessary. In terms of imaging, if they have neurological findings or you suspect that they may have a brain tumor with secondary to previous colorectal cancer, do a CT brain or MRI brain. Thank you very much for watching.